Hi again, everyone. Sorry, the line was cut off at some point. I'm not sure why, but we're gonna start at the moment. I'm gonna start by sharing my screen. If you give me just a couple of seconds, that should be great. Thank you very much. Right, so are you all able to see my screen now? If somebody can shout out and say, or even you can write in the comments if you're able to see my screen at the moment.
Yeah, we can see your screen, it's visible.
Right, that's really great. Thanks very, very much. So again, my name is Dr. Khalid. I'm one of the doctors who are currently working in the UK. It's actually my pleasure to speak to you today. A little bit about myself, if that's fine. So I graduated in 2011 back home in Egypt. Since then, I've been doing medical stuff. So I did general surgery, I did A&E, and currently I'm working as a GP registrar in the UK. I passed my PLAB-2 exam in 2019, and since then I've been giving some sort of mocks, actually to help people to join the UK and to be our future colleague. And I hope you all the best in your PLAB-2 exam. I hope you all pass your exams with a very high score, and I hope you all be our future colleagues. So we'll start our session today. So today we're going to speak about how to enhance your interpersonal skills. Before we start speaking about how to enhance your interpersonal skills, I'm gonna share with you some information about what does interpersonal skills mean, actually. So in a nutshell, so the interpersonal skills actually you need to know about. So the interpersonal skills are the skills that we use every day when we communicate and interact with other people. So both individually and in groups, they include a wide range of skills, but particularly communication skills such as listening and effective speaking. They also include the ability to control and manage your emotions. So again, the interpersonal skills, if you're gonna apply this to the patients themselves and think about this. So interpersonal skills are skills we use every day when we communicate and interact with patients, right? So because we are doctors, we should be dealing with patients actually in different ways. Some people actually work like, as myself as a GP, do interact with people nearly every day. Some people actually do interact with people, but in a different way, like radiologists or whatever. But at the end of the day, we're all going through the PLAB-2 exam, so we should deal with patients in the exam, or role players, but actually they are acting as patients. Right, they include a wide range of skills as your daily skills that you do with your patients. So particularly communication skills such as listening and effective speaking. So you should listen to the patients carefully, and then when you speak to them, your speech should be very effective and clear to them. It also includes the ability to control and manage your emotions. So your emotions, while you're speaking to the patient, should be controlled. You should be, possibly might have heard about the difference between empathy and sympathy. So in a nutshell, empathy meaning that you are very, very aware about the patient's situation, but you're not actually involved in their emotions. You feel really empathetic to them, but if they do cry, you don't cry, for example. So this is sympathy. When they do cry, you do cry. But empathy is you're feeling sorry for the patient, but you are not putting yourself in the same emotions as they are at the moment. Right. So this is like a very small hint about interpersonal skills. So here we move into the next slide, which is doctor-patient relationship. So the relationship between the patient and the physician is based on trust, which gives rise to physicians' ethical responsibility to place patients' welfare above the physician's own self-interest or obligations to others, to use sound medical judgment on patients' behalf and to advocate for their welfare. So the patient relationship, like I said, is based on trust. So your responsibility while you're dealing with your patient, or responsibility even in the exam, to build this sort of trustness. And how to build this, we're going to speak about that in a few seconds. Right. You might have all heard about the patient-centered approach. I'm not sure if you heard about that, but it's a very, very common approach actually we normally use. So what does this mean as well? Because that's actually very important to know while you're dealing with your patient. So providing care that's actually respectful of and responsive to individual patient. So it's very, very important to put that in your mind. Be very, very respectful and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. Right? So put the patient in that position where understand where they are coming from, and based on that, use your clinical judgment, but at the same time, try to appreciate the patient's circumstances. We're going to speak about that in a few minutes as well. Right. Here it comes to the main bit about our today's session. Hopefully this session actually will be an interactive session. So we'll start now about how to improve your interpersonal skills in PLAB-2. So possibly some of you, or even all of you, know about that interpersonal skills is actually a part of the exam, and we're gonna mark against it in the exam, actually in the PLAB-2 exam. So it's very, very important to put that in your mind. Your relationship between yourself and the patient is actually being marked all through the station. So how to improve your interpersonal skills in PLAB-2? So the interpersonal skills actually starts once you begin your exam, and starts by entering the exam's cubicle. So at the first bit, the first second, when you knock the door and say hello, so this is when you do start, or when you are started to be marked in the exam. When you say hello, good morning, so this is when you're gonna actually be, or started to be marked. Right. So let's speak about the general advice for today. So the main thing actually I would like you all, dear PLAB-2 candidates, to put in your mind is to be active listeners. And it's very, very important to put that in your mind. What do we mean by active listener? And I'd like you actually, or any of you, if you've got any information about being an active listener, you can raise your hand and you can speak out loud. Anyone have got an idea about how to be an active listener? Or what's the difference between listening and actively, or being actively listening to the patient, for example? Right. I'll make it as easy as possible. So being an active listener is not only to listen to the patient by your ears. So you should listen to the patient by all what we've got. So concentrate while you're speaking to the patient, and while the patient speaks to you, concentrate with all what we've got. Focus on what the patient says. Put that in your mind while you're speaking to the patient and while the patient speaks to you. So please, please listen carefully to what the patient says to you. Because, for example, if I'm going to speak to you and tell you about my situation as a patient, and I started telling you what happened and everything, and all of a sudden you ask me, all right, so can you tell me when did this pain start? If I've got a pain, for example, and I told you this pain started like a few days ago, and then trying to explain all of my symptoms. So you started by asking me, oh, all right, so can you tell me when this pain started, please? So this means that you haven't already listened carefully to what I said. So concentrate to what the patient says to you. It's a very, very important thing, and a very important tip in the PLAB-2 exam. So put that in your mind. Right. So this is the main bit. The other thing is never interrupt patients, because I've seen that a lot of doctors actually who feel that they are like running late in the station or something, and keep interrupting the patient. The patient speaks to them, and then, all right, and I will ask you a couple of more questions, and then no. Please never interrupt the patient. It's a very, very important skill. Listen carefully and never interrupt. It's a very, very important thing. Be empathetic and respectful, like we said. Be very empathetic to the patient. If the patient says, doctor, I've got this problem like for almost a year now, for example, I'm just giving an example. And then to be empathetic, how to be empathetic and say, oh, I'm really sorry about that. You can say, I'm really sorry, or you can behave as being sorry. So to say, I'm really sorry, it's very important, but at the same time, you should also behave like being sorry. So you should lower down the tone of voice while you're speaking to the patient and say, oh, I'm really sorry about what you've got. It sounds, it's really, really annoying, or it must have been very distressing to you. So you should be very empathetic to your patient. And this is also helps you to build rapport with your patient. So be empathetic and be respectful as well. Whatever the background of the patient is, right? So we're all human beings. We are all here to respect each other. And it's very, very important you put your patient actually in the top priority while you're speaking to them. So always be empathetic and be respectful. Right, consider the psychosocial aspect in addition to the medical aspect to build good rapport with your patient. So psychosocial aspect, has anyone got any idea about what is the psychosocial aspect? Again, if you do know, just raise your hand or even just unmute yourself. And then we're gonna discuss that as well. What is the psychosocial aspect in PLAB-2 exam, or even in your relationship between you and the patient? Anyone has got any idea about that? Right, so the psychosocial aspect is actually, like I said, it's nothing to do with the medical aspect. So it's a complementary thing to the medical aspect. So the medical aspect actually is, for example, a patient presents to you. Just 1 second, sorry, I'm just, oh, Dr. Pachan is saying mood support system, social history. Exactly, that's really correct. Thanks very much, well done. So the psychosocial aspect actually is a very important thing that you should bear in your mind. So psychosocial, how are you doing today? How is your mood? How did that affect your life? Did that affect your sleeping by any means? For example, I'm giving just some examples. So if the patient has got medical illness, this medical illness actually can affect his psychological life, can affect his social life. Psychological life can affect his mood, for example, and his social life can affect his interaction with other people, can affect his interaction at work, can affect his work actually, because, for example, if he's not sleeping properly at night, so this actually affects his ability to continue or to proceed with his daily activities or his daily jobs. It's a very important thing to put that in your mind, the psychosocial aspect. And we're going to do a quick recap about that at last, but psychosocial aspect is a very important thing that's really omitted by a lot of candidates in the exam, unfortunately. But it's a very, very important thing in addition to the medical aspect. So the medical aspect can lead to psychosocial aspect. Put that in your mind. Understand where the patient is coming from. It's a very important thing. And by that, actually also you're building rapport with the patient. One more thing I would like to ask you, great doctors, if you know, do you know when exactly we should speak about the psychosocial aspect? Is that in the earliest part of the station, in the middle part, in the management plan, for example? Has anyone got any idea about when should we speak about the psychosocial aspect and why? Again, if you do know, just you can write in the comments or you can just shout out loud. So the question is, when do we speak about the psychosocial part, or when it's preferred, right? So Dr. Umama says after history, okay, right? Anyone else has got any idea?
Is it near the, while we take the occupational history, for example?
Right, okay, yeah, that's fine, that's good. Thanks very much, Dr. Mohammed. Anyone else have got any idea? Yes, Dr. Bachan, after the history of chronic illness, right, okay. All of these are actually really valid, and I totally appreciate your participation. It's really, really nice. My point of view is the psychosocial aspect should be started as early as you can in the station. So, for example, if a patient actually like presents to you with headaches or whatever the illness is actually, and then they started telling you, oh, doctor, I have been having this problem for like a lot of years, or I have been having this problem actually for like a few months now, it has been affecting myself. Then full stop. Then you start, oh, I'm really sorry. You start by saying, I'm really sorry about that. It should be very, very stressful to you. How are you coping? How are you managing at the moment? Right. And then you can say, oh, did that affect your life by any means? All right. Okay. So why I'm thinking this, it's a very important thing. So first of all, you're not gonna forget about the psychosocial part. Take it from the patient's speech. So the patient tells you that they have got a problem. So you don't just say, okay, and then continue with your questions, your medical question. No, stop at this second and then ask a quick question. How are they coping? How are they managing? Does that affect your life by any means? Does that affect your job by any means? So at that time, it's very, very important. So you're not gonna forget about the psychosocial aspect. And the other thing is you're building rapport with your patient. Building rapport is a very good skill, and it needs very good training actually. To build rapport, to help your patient open up to you, it's a very good skill. And you'll never get this until you do training on this. So to do training on this is by practicing. So practice that whenever you do any PLAB-2, practicing with any of your colleagues or doing mocks with your mentors, it's a very, very important thing to practice the psychosocial aspect and try to include that as early as possible. You can imagine if I start my day-to-day by just sharing the presentation and say, oh, hello, my name is Dr. Khaled. Now we're going to start without even telling you who I am, right? So it's a very important thing to build rapport, to introduce yourself, to let the patient know much about yourself. And then now it's your duty to know about the patient himself or herself. Try to understand where they are coming from. Try to put the patient at ease. The patient, when the patient asks you, how are you doing today? When you ask the patient, how are you doing today? How are you doing is not all about how are you doing medically, but how are you doing in life, right? So what I'm pointing at is a psychosocial aspect is a very, very important aspect in addition to the medical aspect. So please never forget about it. Build rapport with your patient, build rapport where I know that you're a doctor and he's a patient or she's a patient and she presents to you today just to speak about the medical condition, but it's not all about the medical condition. And the other thing is the patient, to break the ice between you and the patient, so you should actually put them at ease. And to put them at ease, it's very important to ask about their psychosocial life, right? So we had a good time speaking about the psychosocial aspect. Now we're gonna speak about ICE. Anyone knows about what ICE stands for? Please shout out loud or write in the comments. I think, or I bet that almost all of you actually know about them, but I'd like to hear from you as well. Did you come across ICE before, great doctors? Right, let's see. Exactly, thanks very much, Dr. Cheoma and Dr. Amoha. Yes, that's really great. So ideas, concerns, and expectations. So let's speak about them in a quick detail. So ideas, so you should check the patient's idea about what they have got. So for example, have you got any idea, Mr. X, have you got any idea about what's going on with you today, right? Why this question is really important? Because first of all, the patient is his own doctor, right? So What I am pointing at towards this is the patient knows himself very well. He might have got some information about himself or herself and why they are coming into you today. They might have seen a lot of doctors before. They might have like been dealing with this situation in any of the family members, for example, so they have the same problem. So you should understand what the patient is thinking. So any idea what's going on with you, Mr. X or Mrs. Y or Z? So it's a very, very important thing. So ideas, any idea about what's going on? Concern, how to ask about concern. It's a very important thing. Hello? If anyone has got an advice about how to ask about the concerns in the exam. And I'd like you all to unmute yourself unless you're gonna speak or participate. That should be great, thank you. Right, concerns, anything in particular concerned about? Perfect. So thanks very much, Dr. Shadi. And what's bothering you? Right, okay, that's really valid. That's really great. Any other thoughts? Right, okay. Mr. John, Dr. Shadi, so what worries you the most? Yeah, that's perfect. That's really, really perfect. Thanks very, very much, Dr. Shadi. Right, so may I know what worries you the most? What concerns you the most? Anything in particular in your mind that you're worried about? So this is very important because I have faced that with a lot of candidates actually who unfortunately don't even know how to ask about concerns. So how important concerns is in the exam? This is a very important question. How important the concern part is in your exam? It's really very important. You can't really imagine how important the concern is. In most of the cases, or most of the scenarios, or in most of the exam stems actually, it says, please address the patient's concern. Please address the patient's concern, right? So despite or even no matter how it was mentioned in the exam stem or not, so it's very important to ask the patient concern. Patient concern is a very important thing. You put that in your mind, please, while speaking to your patient. Never, ever forget to ask about it, at least the concern. I'm saying ideas, concerns, expectations, they are all important. But at least if you're not, or if you do decide that you're not gonna speak to the patient or ask them about their ideas or what they're expecting from you today, so please ask about the concern. It's a very important thing. The concern itself is not all about just to ask them about the concern. So there is another more important thing than asking about their concern. Anybody knows? I asked you about the concern. I'm a doctor, and for example, Mr. X is a patient. So may I know what concerns you the most? And then what's the most important thing to do now? So the most important thing to do now is acknowledge this concern and to try to address the patient's concern at last. Acknowledge this concern. Oh, I'm really sorry about that. If the patient says, oh, doctor, I think I've got cancer. Oh, I'm really sorry about that. May I know why do you think so? Acknowledge that. And why do you think so? And hopefully we're going to address this in the next few minutes. And then when it comes to the management part, please, please never forget to address the concern. The patient thinks they have got cancer. It's very important. My duty now is to either reassure them you don't think that they have got cancer, or to be neutral and say, I'm really sorry, I'm not quite sure about what's going on at the moment. However, to be on the safer side, we're going to do X, Y, and Z. We're going to refer to a specialist, for example. So it's a very important thing. Address the patient's concern. Expectations. So where about, when, so let's forget about when about at the moment. So expectations, how to ask about expectations. Anybody knows? Expectations. How to ask about it? Right. So expectations. Right. Yeah. Here we go. We've got very lovely answers here. Right. So Dr. Pachan, what are you expecting out of today's consultation? Good. Dr. Emoha, anything else I can help you with? Right. That's really good. That's really good. But anything else I'd like you to help or you would like me to help you with? It's a very, very good thing. But I'm speaking about the expectation, what the patient actually expecting from us today. Because guess what? You might know or you might don't. The patient actually comes to you today with an agenda, right? The patient, I'm not speaking about the role players in the exam, I'm speaking about the patient. The patient might have done a lot of research before he comes to you in the clinic today or in the hospital, possibly. Most of them, they Google what they have got and they get answers from Google actually, and then they expect you to do X, Y, or Z that they have found in Google. And your duty actually is, if you do agree with that as a doctor, because actually Google is not the safest way actually to treat yourself. So otherwise we all, as doctors, we will sit at home just watching people or watching Google doing some medical stuff or like treating patients. So the patient presents to you today with an agenda in most of the cases. Not only Googling, by the way, I'm also pointing at the patients might have had like a kind of relevant or had the same situation. For example, a patient actually presents to you today and she's worried about like endometriosis, like any gynecology issue. And she had like her mom or her aunt actually has got the same problem and she was treated by hormonal treatment. For example, I'm just giving some examples. And then she comes to you and she has got an agenda in her mind. So it's very important to know what the patient is coming from, what the thoughts are at the same time, what they are hoping from you today to do. Because you might end up by saying, okay, so we're doing 1, 2, 3, 4, 5, but the patient came in here to ask for like number 6 or number 7 in her mind, okay? So understand what the patient needs from you is a very important thing. Right, Dr. Shedi, is there anything else you're expecting from our today's consultation? Yeah, all right, anything else is good, but you can say, what are you hoping from us to do today? Anything that you're hoping from us to do at the moment, right? Anything that you're expecting from us to do today. So expectations is a very important thing to do. Like I said, if you decide and if you feel that you're running out of time and you haven't addressed the patient ideas, expectations, or concerns, at least, I'm saying at least because you should do them all, but at least ask the patient about their concern. Right, so when it is ideal to ask about ideas and when it's ideal to ask about concerns and then expectations. From my point of view, ideas is a very important thing to put that early on in the station while taking history from your patient. So Mr. John, any idea about what's happening today? Any idea what's going on with you, right? Like I said, why is that? You're building rapport with your patient, and the other thing is the patient might help you. Oh, doctor, I have got headache. Oh, doctor, I think I might have got migraine. Why do you think so? Because actually, my father has got migraine, and he had the same problems before, the same presentation, same symptoms. So I think I might have got migraine. All right, but it's not always the case. Don't rely on this in the exam, okay? But ideas will give you a very good information about what the patient is coming from. At the same time, is building rapport with the patient. Concerns also should be done as early as possible. And why I'm saying this? Because if, for example, if the patient comes to you with headaches, I'm just giving examples, and then at the end, you ask them about every single differential, apart from one thing, which is in the patient's mind. And then at last, and just like 30 seconds remaining, and before your exam actually, or before your station ends in the 8 minutes, then you ask the patient and say, Mr. John, have you got any concerns for today? doctor, have I got cancer? Have I got brain cancer? What will you realize is you haven't asked the patient about cancer symptoms, loss of weight, loss of appetite. Have you got early morning sickness? Have you got any neurological symptoms, such as any arm weakness, leg weakness, slurring of speech? You haven't asked this. And then 30 seconds is remaining and you're asking the patient if they have got concern. You will never end up by addressing the patient concern, because you say, oh, I'm really sorry, I forgot to ask you, have you got any concerns early on? So may I ask you at the moment, have you got any early morning sickness? Have you got any headaches? Have you got arm weakness, leg weakness? Right, so we will never address the patient concern. At the same time, you missed this part in the exam. So understand the patient's concern and try to address that at last. So understand the patient concern early on and try to address the patient's concern in the management plan. It's a very important thing. Expectations. So I would prefer expectations, actually, if we do say that after examining your patient, or even before examining the patient, you can say any things that you're hoping from us to do today. You can do that either before examining the patient or even after examining the patient. And like I said, why do we have to do that early on? Don't say that at last or at the last second, anything you're hoping from us. Because actually, like I said, the patient presents you with an agenda. They might expect you to do something that they have read about, and now you're telling something different to what they have read. So they might feel that this doesn't really make too much sense to them, despite you might be very, very correct. But if the patient says, oh, doctor, can I go for, I heard about like herbal medications can actually treat migraines. Is that fine to do that? Right, so now I understand where are you coming from. However, like the NHS actually doesn't really accredit this sort of herbal medication, but we've got other treatment options that we can offer to you at the moment, and hopefully they could help. Would that be fine by you? Right? So expectations is very important to do, but like I said, try to do that at least before examining the patient, or even after examining the patient is absolutely fine. Right. Okay, so let's move on to the next slide. Right, so assess a patient's knowledge about their provisional diagnosis. It's a very important thing, actually. Do you know why? I'm giving an example of a patient who presents to you today and says, doctor, have I got meningitis? And you didn't assess the patient's knowledge about meningitis. So it's very important to know why the patient thinks about meningitis. May I know how much do you know about meningitis? So know how far the patient knows about meningitis, because she might have got wrong information about meningitis. She might say, doctor, is it a sort of brain infection? Is it a sort of brain tumor or brain cancer? So, all right. So meningitis is actually all about brain covering infection. So brain infection could be what we call encephalitis, and meningitis is a brain layer, brain covering infection. So that's a different thing. So the patient may have got wrong information about what she has got, right? Or what she thinks that she might have got. So please assess the patient's knowledge about what they think. So, doctor, have I got meningitis? All right. May I know why do you think you've got meningitis? All right. And how far do you know about meningitis, by the way? How much do you know about meningitis, right? And your duty, actually, if the patient has got wrong information about the disease or the provisional disease that they have got, to correct this sort of information to them, right? If she says brain infection, no, it's not brain infection. Okay, that's totally fine, but it's not brain infection. It's a brain covering infection, right? Then, two-way conversation. Two-way conversation. A lot of doctors actually, unfortunately, do struggle to build up a two-way conversation. Two-way conversation is basically whenever you're speaking about the management plan in particular, and then not trying to give the chance to the patient to tell you if they have got any further questions. So the patient also might have missed some points of what you have said to them in the management plan part. So For example, if you're telling the patient, oh, you've got migraine, and this actually is a kind of headache that's really common to happen and happens in one side, sometimes it travels to the other side, and it's a very benign thing, we're going to treat you, blah, 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 blah. And the patient might have missed a lot of things that you've said to them. So you can say, you can, to build a two-way conversation by telling, are we on the same page? Is that okay so far? Any questions at all? Right? So two-way conversation. Two-way conversation is a very important thing. In case of breaking bad news, break bad news in layers. Anyone has got any information about how to break bad news in layers? Please, again, shout out loud or mention that in the comments. If a patient, you know a patient, or you have received a letter from a specialist saying that Dr. X, unfortunately, your patient has been diagnosed with brain cancer. Unfortunately, your patient has been diagnosed with brain cancer or breast cancer. So to break this news in layer to the patient, it's a very important thing. We're going to speak about that in detail because it actually takes a long, long time. But what I mean by break the news in layers is, don't say, Mr. X, hello, how are you doing today? I'm really sorry. I have received a letter from a specialist and unfortunately I've got cancer. Sorry about that. So that's really harsh to tell. So really, really, it's a very important thing. Build rapport with your patient. At the same time, break bad news in layers. So Mr. Y or Mr. Z. So as you may know that you had this sort of investigation like a CT scan or an MRI scan. And sorry, Dr. Patchen is saying we have to follow best case, worst case scenario. Yeah, that's totally fine and it's really valid. But like I said, if you do know that this patient actually has got cancer, I'm not speaking about you think this patient might or might not have got cancer. This patient has already got cancer. It's been confirmed in the MRI scan or the CT scan, and then you're breaking this news to them. So I am really sorry I have received your investigation result by the specialist. Have you got any idea about how it's going with you at the moment? Before we start, do you need anyone to be with you in here today? Right. So as you may know, we did this brain scan actually to rule out the reason behind your chronic headache. And what it says, I'm really sorry to tell you that it has got some sort of a mass in your brain, unfortunately. And this mass is actually, I'm really sorry to say that, I'm really sorry to have to break this bad news to you. It says that you've got cancer. I'm really sorry about that. Right, so it's all about your tone of voice. It's all about how you break this sort of news to the patient, not just, oh, you've got cancer. You should be very empathetic to this patient. And at the same time, to break the bad news, and I might conduct a session about that if you like, it's a very good skill actually to try to help the patient. And to help the patient is not only by telling that you're gonna refer the patient into a specialist at the moment in like a fast-track pathway or a 2-week wait. They already been known by the specialist, so you're gonna refer them anyway. But the problem is, this patient will go home, actually will be very, very depressed. How would you help them? So this is the point. To help them actually is to offer support, offer emotional support, right? So breaking bad news, be very empathetic, break in layers, and offer support. Right, angry patient, and it's a very common thing actually to deal with an angry patient. I wouldn't say it's always the same, but a lot of people actually, and I do understand, I didn't know why you can like speak to an angry patient in the exam before I came to the UK. However, I understand where they're coming from because it's a waiting list actually to be seen by the GPs, or even when they do go to the emergency department, they might wait up to like 6-7 hours until they're being seen by the doctor. So you should understand why this patient is actually angry, why he is like, might raise a tone of voice, why he's speaking to you or whatever, they might shout or whatever. You should absorb all of this You should understand why this patient is angry. It's not about, oh, please don't shout at me. Oh, please don't raise your voice. No, this is not ideal because this patient has been exposed to a lot of pressure actually. And you are the one who is actually, or the first line who is dealing with him. So to deal with an angry patient, acknowledge what the patient is coming from. So for example, you say, I'm really sorry, I missed your blood sample. For example, I took a blood sample from you and I did really forget to label the blood sample. So the patient will start getting angry, for example, if they do. So acknowledge, I can understand that you're really worried. I can understand you're really frustrated. So this is how to acknowledge the anger of the patient. I can understand that. Then apologize. Apologize to the patient. I'm really sorry about what happened. This shouldn't really have happened. Please accept my apologies on behalf of myself and the medical team. And then find solutions to help them, right? So this is like a quick bit about some of the interpersonal skills that you might face, but still we've got a lot of things to do. So we'll go further with our slides. If you give me just 1 second. Right, so I'll stop the screen share at the moment. I'm going to share examples of poor consultations because I do think in order to understand how to build up a good consultation, you should know how the poor consultation actually goes, right? So I stop the screen now. I'm going to share 2 YouTube videos. And at the end, I'd like to hear from you. What do you think it went right? What do you think it went bad? In this sort of consultations. So if you give me just 1 second, and now I'm gonna share my screen. Just 1 second. Right. Right. 1 second. Right. If you're not able to hear it, just let me know. Thank you. If you give me just 1 more second, the screen is visible, but I'm not sure if it's actually, yeah, here we go. Just 1 second. Yeah. Here we go.
Come in. Hello. Hello. Nice to meet you. I'm just back again.
Yes, yes. Yeah, it's not that long since you were last here.
I know, but I'm really not happy with these heavy periods I've been
You're not
having.
happy?
Well, no, I've been to see you several times, and you've put me on tablets, and you know they're just not working, and
But you've
I'm really thinking I want to.
Excuse me. You've not had the time to take the whole course of tablets. So how do you know they're not working?
I'm just far too busy. I have a really busy, hectic life. I'm running this major organisation. It's having a huge conference, and you know I've been thinking a lot about it.
But you're
and
not
I
too
just
busy
want to
to
have
look
a
after your health.
hysterectomy.
You can't. A hysterectomy?
Yes, that's what I want. I want to be referred on so I can have a hysterectomy
Well,
and just get this whole scenario finished and done with.
I think you're overreacting. I think that you're
But
being...
you don't live my life. I'm really
Can I
struggling
just tell
here.
you what your options are here? Let's just
All right,
take a
I'll
step
listen
back
to your options.
and listen
Right.
to your options. First of all, tell me, what was the problem with taking the medicine? What was the problem there that you couldn't take the medicine as prescribed?
Well, I mean, I'm busy, I'm travelling,
We're all
I'm
busy.
not always
But if this is a
remembering to
priority
take these
for
tablets
you,
with me.
you need to
Well,
make it a priority.
I've already made my mind up that I'm not wanting to go down the tablet route. It's the hysterectomy.
Okay.
Hysterectomy that I'm
So
wanting.
the last time you were here, we discussed having a coil. That can be quite effective in helping with heavy bleeding.
I'm not interested in that.
Well, that's a non-medical alternative?
I really, as I say, my lifestyle is such that I need to move on. I've been taking time off work. I work in a male environment. It's starting to be flagged up as an issue, and I'm not prepared to have that compromise my career.
Yeah.
So I really want to go ahead and have a hysterectomy.
See from your records here that you're 32.
Yes.
I'm afraid that I'm not prepared to consider even putting your name forward
But
for that.
it's my choice. It's
No,
my
you're too
decision.
young. You might want children and regret it.
I don't want children. I've already made that life choice.
Yeah.
I'm quite happy.
It might
thank you.
be your decision if you want children, but as a doctor, I'm not prepared to make that decision and to verify that decision for you.
But as a doctor, you're there to listen to me.
Yes.
And help me.
And I have been
with those
listening to
decisions.
you for a period of 6 weeks
But
now.
I'm feeling you're not actually listening to me.
I am. You have a heavy
Well,
period,
you've
you
made
have
your
a heavy
decision, but you're not
lifestyle,
listening to my
and you're
decision.
wanting somebody to
I'm
fix
sorry,
it for you.
I
A
think-
quick fix.
I think I'm going to have to
it's
go
too-
private. I'm
It's
sorry. I'm
too
just going to.
invasive what you're asking.
You're not listening to me. I appreciate your time, but this is not working for me. So I think I'm going to have to go elsewhere.
I think that would be for the best, because I can't help you any further.
Okay.
Thank you.
Come to that agreement. Thank you very
Okay.
much.
Thank you.
Right. How you all think this conversation went? Anyone has got any idea? Anyone who's actually would like to participate and say, how do you think this station went, or this sort of conversation went between you and the patient, or between the patient and the doctor? Was it really a very nice consultation? Poor consultation, perfect. And why do you think so? Why was it a poor consultation? Oh, just 1 second. Sorry, I'm just for just 1 second. Give me a second. Here we go. Right. So, why do you think, guys, that was a really poor consultation? So I'm reading out loud your lovely comments. So Dr. Patchen, poor consultation, right? Not listening to the patient concerns, perfect. No empathy, not even sympathy, perfect, perfect. Dr. Amoha, interrupting the patient, not listening, no empathy, right? Imposing her own ideas, that's really, really agreed. Rude behavior from Dr. Patchen. Sorry, you're saying rude behavior of the doctor, perfect. Interrupting patient in between, absolutely. She kept interrupting the patient many, many times. I totally agree with you. Thanks very much, Dr. Patchen. From Dr. Umaima, a lot of interruption. Sorry, Dr. Umama, I'm really sorry. I'm really sorry if I'm just pronouncing the names incorrectly. I'm really sorry about that. But that's really, really appreciated, Dr. Umama. Absolutely. A lot of interruption all during the consultation. And Dr. Katrina, not reflecting her concerns, so the patient felt like she was not heard, right? And Dr. Patchen says, even I felt disrupted by watching the consultation. Absolutely, absolutely. So do I. So do I. It was a very, very interrupted consultation, and it's a very unuseful consultation. I'm feeling very, very pathetic to this patient. Actually, she didn't choose the right doctor to go to. Right, I'm gonna share another video. I'd like also you to watch it and then tell me your opinions at last. Give me just 1 second. I'm gonna adjust it for you. Just 1 second, and then we will come back. Right. So if you're not able to hear it or to see it, just let me know, and we're gonna start.
Hi, I'm Hannah. I talked with you, I know, the other day, but I just wanted to touch base today, you know, about your stuff, your situation. So I read your chart, and I know we talked last time. Are you still feeling depressed? Yeah, a depression, so okay. Depression. And I know you're feeling depressed now, but I felt depressed before, and it will pass. Like, you'll get over it. It's not that big of a deal. And so this depression, why are you feeling depressed?
Well,
Oh, wait, sorry, I had another note. Something else I wanted to ask you before. No, why, or is that depression what brought you in here?
Well, I OD'd earlier
Ooh,
because I was
depressed.
really sad.
Yeah. Okay, so that overdose we'll have to talk about. So then why are you feeling depressed?
Well, I was abused earlier. I don't know, I just don't.
I mean, your life
I
doesn't.
do.
I looked in your chart, and your life doesn't seem all that bad. So this depression, I think you can get over it. Yeah. Let me look at my notes here. I know we saw some stuff. Oh, hey. Yeah. Can I talk to you later? I'm gonna finish talking to her. Okay. Sorry, I lost my train of thought. Let me look at my notes here. You got the abuse, the overdose. So can we talk about these thoughts? Oh, that area. Do you want to, are you still having those thoughts?
No.
No? Okay, then. Great. No thoughts? Because I mean, if you're having them, it's kind of like, I don't understand why people think of like killing themselves. It's really very weak of them to do. Personally. But anywho's, oh, hold on a second. Hello? No, I'm at work right now. Yeah, you know at Belmont. Yeah. I'm gonna talk with this patient here. Yeah, and I'll call you back. Okay. Okay, bye. I'm sorry. Yeah. Anywho, so let me look at my notes. But so you, those thoughts we were saying, what were you saying about those? Did you have them? I forget.
Well, no.
No. Okay, that's great. I'm glad. So are you feeling better then?
I guess a little.
Yeah. So what do you think has worked in your therapy?
I like talking to the therapist.
One-on-one? Okay. Well, do you want me to see if your doctor's available? I can
Yeah.
totally arrange that. Okay, I'm gonna go check that then right now.
Okay.
Right. Just 1 second. Okay. Did you all see this consultation, doctors? Right. I have got very, very lovely comments, which was really great. Perfect. So, Dr. Ali, poor body language, yes. Close posture, yes. Close questioning, no active listening at all. Perfect. Dr. Katrina, like a chair in a pub, absolutely. I agree. Dr. Ali, again, inappropriate gesture, absolutely. No focusing on non-verbal cues. Perfect. Not minding her work, yeah. Non-meaningful consultation. Right, perfect. Dr. Pachan, it seems like the patient has depression and the doctor has mania. Right, no eye contact at all. Perfect. No honest feedback from the patient, as she wouldn't feel like open up with such a doctor. Absolutely, absolutely. And she picked up her phone during the consultation as well. And she, I mean, yeah, it's a very, very poor consultation. Please, doctors, don't do that. Dr. Pachan, no voice modulation, harsh tone. Exactly. That's really perfect. Right. We're gonna crack on with our presentation. Give me just 1 second again. Yeah. Here we go. I hope you all enjoyed this sort of poor consultations. Like I said, please, doctors, don't do that while you're not in the exam, but even while you're speaking to your patients. Please, doctors, because it's highly unlikely that it happens in the real life situation, but it might happen, and I have seen that by my own eyes. Right, give me just 1 second. I'm gonna crack on. Right, can you all see my screen? Good. Right. Perfect. Thank you very much. Right. So I'm giving you an example about a normal situations that you might find, might or might not, something like that you might see while you're practicing with your colleagues. So an example is where you are. So this is a STEM. STEM meaning that it's like a kind of, I would say, a module or something that you might find in your exam. I mean, the STEM, the structure itself. I'm not speaking about this sort of scenario or something that you might find in the exam, but I'm speaking about the structure of the STEM that you might find before you enter your cubicle, before your exam starts. So where you are in FY2 in the GP practice, who's a patient is Maria, 40 years old. She presented to you today with headache. What you should do, speak to the patient, address her concerns, and speak about your management plan. Right, so again, you're in FY2, you're always FY2 in the PLAB-2. In the GP practice today, who the patient is Maria, 40 years old. She presented to you today with headaches. What you should do is speak to the patient, address her concerns, and speak about your management plan. Right. What I'm gonna do now is I'm gonna like give you fresh examples about what we can do in such station or even in any of the stations or while you're speaking to your patient anyway. Right, so the main thing you should do whenever you start the station is introduce yourself properly, right? Your name, your role, and which department you're working at. Your name, you can say your full name or your first name, it's fine. Your role, what you are doing here. Are you an FY2? Are you a specialist? Are you a consultant? Are you a registrar? So it's a very important thing to say what you, or what's your name and what's your role and what are you doing here? Because it's very important. I've seen that a lot of patients actually complained because they find the doctor that he didn't introduce themselves and they say, I saw that he's a nurse or she's a nurse. I didn't know that they are doctors actually. Honestly, this happened, I swear. People actually can complain about this. So say your name, mention your name, your role, and which department you're working at. Confirm the patient's name and date of birth. Everybody knows this, why this is important actually. It's a very important thing to confirm the patient's name and date of birth. It's very important. Any ideas? Right, to make sure the right person. Yes, sometimes patients come with same names. Exactly, I've seen that many times. For example, a patient's name is John Smith. So you will actually be surprised that you can find two John Smiths in one go, in one shift, for example. So you should confirm the patient's full name and date of birth. So it will be impossible, actually. I would say it's a very, in a very, very unreal occasion, it will happen that you might find two John Smiths with the same date of birth. No, it will not happen. So what's the difference between confirming the patient's age and date of birth? Why should we confirm the patient's date of birth, not age? Age is fine. You're not gonna be marked against asking the patient's age, not asking them about their date of birth, but date of birth is really very accurate. You might find two John Smiths who decided to present to you today and they are aged 70 years old, for example, and they decided to present to you at the same time. But you will never find two John Smiths who has got the same date of birth on the same shift. You will be too unlucky, actually. So date of birth is really nice to ask about. But like I said, you can ask about the patient's age, is fine, but date of birth is really nice. And that should be enough kind of confirming the patient's identity, actually. You shouldn't do more than ask the patients about their address while you're having like face-to-face consultation. It doesn't really make much sense. But if you're speaking to the patient over the phone, you can confirm their first line address because you can't really visibly see them. You can ask them about their first line of address. Ask them how they would like to be called. Don't use how would you like me to address you. This is in the GMC do and do not. So do not say how would you like me to address you because it's too formal to ask how would you like me to address you, right? So ask them how would they like to be called. believe it or not, I have seen that a lot in my life since I started working in the UK. A lot of people actually who has got first name, last name, but they do prefer to be called by their nickname. Giving an example, you've got a patient, her name is Maria Johnson, and she's preferred to be called Rose. So if you keep calling out for her, Mrs. Maria Johnson, if you're like for in the emergency department, I'm calling out for Mrs. Maria Johnson to be seen or whatever, and then say, Maria Johnson, and she doesn't keep looking at you because she doesn't know that you're calling out for her. But when you say Mrs. Rose or Rose, she looks at you. I've seen that many times, right? So how would you like me to call you? Patient's name is Michael Smith. How would you like me to call you? You can call me Mike, right? You can call me Mike. And I've seen a lot of doctors who say, hello, my name is Dr. whatever, and then say, can I call you Michael? Doesn't really make sense. You don't please suggest what the patient should be called. They should tell you what they prefer to be called, right? So how would you like me to call you? How would you like me to call you? All right. So Dr. Ali is saying a patient came with the name John Smith. Nurse called him John. Patient was like, no one calls me John. People call me Johnny. Nurse was embarrassed. Absolutely, absolutely, totally agree. This really, really happens. Really happens. You can't really. I didn't know that until I was involved actually by seeing patients in the UK, so I know what I'm saying. And say nice to meet you. It wouldn't cost you much when you say nice to meet you. Nice to meet you builds rapport in the early seconds. Nice to meet you, John, or nice to meet you, Mike, or nice to meet you, whoever the name is. Then an open question. How can I help you today? Oh, that's a very important thing. How can I help you today? I had this debate actually with one of my colleagues, my senior colleagues previously, who said, how would you like to start your station? And I said, I can see from my notes today that you came in here today because you have got whatever the problem is, right? But he said, you might argue or you might say, oh no, it's fine. He said, how can I help you is the best way to start your consultation with. And that's because the patient, you might read in the stems, the patient came in with headaches, for example, and then they came to you today because today they had like vomiting, right? So they had an appointment that spoke with you a couple of weeks ago because of headaches, but today they've got vomiting, and vomiting is actually that concerns them. So if you start by saying, hello, I got to know from my notes that you've come in today with headaches. Is that correct? Yes, doctor, but the reason why I'm here today actually is because of my nausea. I have got nausea. I have got vomiting. It's really horrible. I can't really manage this, right? So don't assume why the patient came in here today. It's one of the things. But I'm not saying that if you take it from the patient's stem and say, I can see from my notes that you came in here today because of your results. Am I correct? I'm not saying that this is really bad. It's fine. But how can I help you today is a very good open-ended question. It gives the patients a chance. It gives them the microphone to express themselves. They will tell you what or why they are here today. So it's a very important question. Never forget to do that early on in the station. Don't start by, I know that you've got headache. Is that correct? Can you please tell me how bad your pain is? Can you please tell me how this pain is referred? Can you please tell me, or can you please score this pain for me between 1 and 10, when 1 being the lowest pain and 10 being the highest pain? You will be surprised if you ask, how can I help you today? The patient will tell you almost everything you need to know. And then your decision now, or your turn now, is to ask the patient about the things that they haven't told you, right? So give them the chance to express themselves and then take it from there. Right. Try to use closed questions later to control your time management. Like I said, you might argue and say, oh, I should know everything about the patient, but closed-ended questions are the questions that start with, can you please tell me, for example, if a patient presents to you with a problem or like being obese, and then they have got a problem with their diet, okay? And then you say, could you please tell me more about your diet? The patient starts, oh, doctor, early morning, I do eat some cereal, I do eat some bread, I do eat some beans, but when it comes to the afternoon time, when I have my lunch, I eat chunky food, I eat blah, blah, blah. And then when it comes to the evening time, I do like jam a lot, actually, but at the same time, I do eat yogurt. So I'm not considering myself eating healthy. So you can imagine that this patient actually spent around, like, I would say like 30 seconds actually explaining what they eat. And then you might find that at last the patient is not eating healthy, and that's it. This is all what you needed to know. I know it's very good kind of consultation to ask the patient about what they eat and try to know what's actually spot on or what's actually not working good for them. But in 8 minutes, it would be too challenging to do so. I have got a question. One example I can quote, the patient is on medication having side effects. I think it is better to ask, how are you getting on with the medications instead of, do you have any side effects of the medication? Exactly. Also, I would say about the example that I did really give, so about the diet itself, and you might argue with that, but about the diet. So do you consider yourself eating healthy? Do you eat junky food? Do you drink too much coffee? Do you drink too much tea? Okay, so you can ask about that rather than tell me more about your diet. Walk me through your diet. Okay, I have seen a patient, sorry, I have seen a doctor, actually, we were doing a mock session before, and I presented with like, as a lady actually, who actually has got a problem, just let's say polycystic ovarian syndrome, and you should ask about the periods, the 4 Ps. Then he started by asking me, tell me more about your periods. No, sorry, he didn't say that. But what he said is, walk me through your periods. And that was a very embarrassing question. Walk me through your periods. So I was really surprised when he said so. So he could have asked me, are your periods regular? Do you get any sort of heavy bleeding, for example? Okay, any breakthrough bleeding or any bleeding in between your periods? Okay, so you ask specific questions. This is what I'm pointing at. Yes or no questions, okay? Questions that end with yes or no. The answer is a yes or no. So start with an open-ended question, and later on, you now got good information about the patient. Ask close-ended questions. Good. Then listen actively, like we said earlier, be empathetic and consider the psychosocial aspect. We mentioned about that. Ask relevant questions only. If the patient presents to you with headache, don't ask them, for example, about their sexual history. It's very unlikely that could be related actually to ask about the sexual history in that situation, isn't it? So ask only relevant questions. We mentioned also about ICE. Give a good idea about where the patient is coming from and address the patient concern, like we said earlier. Praise the patients if they do anything good. For example, if they stop smoking. If a patient actually says, or you do ask a patient, do you smoke at all by any means? And what kind of smoking do you do? Oh, doctor, no, I don't really smoke at the moment. I have quit around a couple of years ago. Oh, that's really good. That's a very good step. I totally appreciate that. Well done. Okay, so please praise the patient about what they are doing good. It's a very good thing, and it's a very good encouraging thing, and gives a very good positive vibe to the patient. Signpost before asking alarming questions. So if the patient comes to you and their main concern, for example, like cancer or something, they are really worried about cancer, and then you start your maftosa kind of thing. You might have heard about the medication, allergy, family history, travel history, occupation, smoking, alcohol, diet, exercise. This is what maftosa in a nutshell. And then you ask, have you got any history of cancer in your family? The patient will start getting worried. They are waiting to hear from you about their examination, about their camera test result, for example. And then they haven't got any problem, actually, apart from like Barrett's esophagus or so. And then you start by saying, have you got any cancer in your family? This is really not good. So you can say instead, I might ask you an alarming question, but please don't get alarmed. It's just a part of our routine consultations. So any family history of any cancer in the family, or any like stomach cancer, or any gullet or food pipe cancer, right? This also belongs to signposting, also belongs to asking about sensitive questions. So are you sexually active at the moment? Don't jump to say, all right, so are you sexually active at the moment? Right? You practice safe sex, and the patient can sometimes not understand why you're asking this question, which might put you in a very bad situation, right? So put that in your mind. Relevant, sensitive questions, really signpost before. A couple of specific questions about your lifestyle, if that's fine. Do you smoke at all? Right? Okay. Do you, I would say, do you do any drugs by any means? So this is also a sensitive question. So don't ask this straight away. You can ask just specific questions if that's fine. Don't write just routine questions. And do you use any illicit drugs by any means? No, that's fine. All right. Okay. Relevant, sensitive questions. So these are the sensitive questions, right? Sensitive questions about sexual history, about drug use, all of these things you can just signpost, but very quick signposting. You don't have to say, right, so I might ask you an intrusive question, or I don't think that actually makes any sense to me, because actually the patient comes to you today, they're expecting you to ask them questions, but you're just signposting, just specific questions, if that's fine. Are you sexually active at the moment? Do you practice safe sexual activity? Have you got a stable partner? All right, so this is signpost, this needs signposting, please. Right. Examining the patient should be explained in detail and justified, especially or specifically if you are doing an intimate examination. And never forget a chaperone in that case scenario. Examining the patient should be explained in detail. I will give you an example. A patient comes to you today, they have got urine issues, a male patient, aged 65 years old, and you want to examine their back passage. And you started by telling them, Mr. John, I would like to examine your back passage. Is that all right? And then the patient looks at you, and then he will say, why do you want to examine my back passage, doctor? I would like to hear from you what might have been done better than asking, I would like to examine your back passage. Any thoughts? The patient has got urine issues, remember, and you want to examine his prostate gland, but you told the patient, or you asked the patient to examine their back passage. And then the patient is really not understanding, why do you want to examine their back passage? How can we overcome this confusion? And the patient might feel embarrassed because they don't know, why do you want to examine their back passage? I'd like to hear from you. Right, Dr. Ali, in order to know more about the cause of your illness, perfect, I need to examine you. I'll be doing this. Yes, perfect. In another way, you can say, I'd like to examine your prostate gland, actually, in order to make sure that we're not missing anything. And the only way we can do that is via your back passage. So I would like, if I can examine your back passage, is that so right? Okay. Dr. Katrina said, when it comes to urination problems in men, we need to check the prostate gland. So if it's okay to examine your prostate, perfect, perfect, perfect. Now you got what I mean. Any intimate examination, vaginal examination, breast examination, penile examination, back passage examination, all of these are intimate examination. You should justify why you are doing this. And never forget a chaperone, whether you are a female or a male doctor who are examining a female or a male patient. All right, so don't assume because you are a male doctor, the patient wouldn't need a chaperone because they need to be examined, or I mean, their prostate gland needs to be examined. Okay, so never assume this. You please offer a chaperone in both situations with any intimate examination. Perfect. The above also applies if you would like to do investigations. What I mean by that is, whenever you are ordering any sort of investigations, please explain why you're doing this. Mr. John, let's give like an example about this sort of patient who presents to you with urinary symptoms. and you want to do some sort of investigation. So, Mr. Jones, thanks very much for letting me examine you. Now I'm gonna request some bloods for you. Is that all right? And then the patient starts by thinking, why does this doctor want to order some blood investigations for me? What kind of investigations? Believe me or not, a lot of patients will ask you why they want to do these investigations. Right, so I would like to arrange for some blood investigations, including a full blood count and what we call a prosthetic specific antigen, just to make sure that we're not missing anything. In addition, we might need to do a urine dip to make sure that we're not missing any blood in urine, any sort of infection in your urine tract as well. Would that be fine? Okay, justify, I'm doing some sort of bloods, I'm doing urine test, and why I'm doing this, in order to make sure that we're not missing anything when it comes to your urine tract or your prostate gland. Okay, justify. Explain the examination, investigation results, and avoid jargons. When you're speaking about your management plan, please explain what you found on examination. Believe me, this actually very, very vital and very important. When you deal with a patient and then you stopped the examination, you completed your examination, right, and then at the same time, the patient, okay, all right, and you finish everything, and then you started by saying, do you know what's going on with you? All right, was the examination fine, doctor? Did you find anything on examination? Believe me, the patients actually are very, very concerned to know what did you find during the examination. Very important. So when I did the examination, it was actually fine. I only found some sort of enlargement of your prostate gland, which I do think is nothing actually to worry about at the moment. This is what we call benign prostatic enlargement. So do you want to hear about that? Is that all right? And then explaining what you did find. Investigation results as well. We did investigations. If the examiner gives you like findings about your investigation requests, then you also try to explain that to the patient. This actually justifies your diagnosis, tells the patient why you think this patient has got benign prostatic enlargement and not cancer. Fortunately, your PSA test came back all fine, so we're not worried about cancer at the moment. Hopefully, everything goes all right. But what we're thinking you've got at the moment is what we call benign prostatic enlargement. Avoid jargons. How to avoid jargons? It's a very important thing, but it's an easy thing at the same time. But believe me, a lot of doctors do that in the exam. Benign prostatic enlargement, but they don't say, do you like to hear about that? They don't explain what benign prostatic enlargement is. Okay, they say, you've got benign prostatic enlargement. Do you want to hear about the treatment, for example? No, explain what the prostate gland is. Okay, a small sized gland that's situated below the neck of your bladder. Actually, we as men, when we grow older, this prostate gland actually grows older with us, and by growing older, it gets bigger in size. So that's actually considered as a normal growth of the prostate gland. However, if you're keen to hear about the treatment options, so we can speak to you about them in detail if you like, right? So avoid jargons. And even it happens, we're all human beings. If you say to the patient or ask the patient a question that might sound like ununderstandable, or even if you tell the patient like a medical jargon instead of a layman language, you can apologize for that. And then, sorry, I'm really sorry if I use the medical jargon. I meant whatever. I meant like in a more easy way or a more layman language way, right? So avoid jargons in the exam. It's a very important thing. Two-way conversation. We said, like, are we on the same page? Does it make sense to you? Is that okay? Any questions so far? And the most important thing is don't use this a lot. Why does that I mean? Don't use the above thing a lot. So yeah, two-way conversation, I mean, but at the same time, not with every single step to say, is that okay so far? Are we on the same page? Mr. Joan, I think you have got what we call benign prostatic enlargement. Are we on the same page? And I'm going to speak to my senior. Is that all right? I'm going to speak to you about the management plan. Is that okay with you? No, I don't want to do this. I don't want you to do this. I want you to, yes, okay, with every bulk, you can say you complete your diagnosis and you explain diagnosis and give leaflets and everything. And then, is that all right so far? And then speak about the rest of your management plan. And then, are we on the same page? So you can use it like once, twice, maximum 3 times during the management plan. You've only got like 2 or 2.5 minutes to speak about your management plan, unfortunately. So please don't waste your time. You can ask this, but after every bulk of things after your structure of the management plan, and we might arrange a session to speak about the structure of the management plan, but don't use that too much, right? Good. Okay, so we'll move on to the next slide then. Yeah, explain the diagnosis if present in detail, like we said, and offer leaflets. Believe me, here the people in UK, they do really like leaflets. And why is that? Actually is because 80% of what you're saying to them today is going to be forgotten. So what you say to the patient, I would say even 90%, not even 80%. So the patient will absorb 10% of what you told them. When they go home, they will forget every other thing you mentioned to them. So only 10%. So you say benign prostatic enlargement, and then when the patient goes home, I forgot the doctor told me what I have got. Oh, I can't really remember. Oh, but if you give them some leaflets to read about benign prostatic enlargement, how is that treated, or how the symptoms are actually treated, the patient will be very thankful to you, because they know what the diagnosis is, they know much information about benign prostatic enlargement and how is it treated, and they can carry that with them. Even if they absorb all of the information and they do forget at some point, they can return back to this leaflet. So leaflets are very, very good ways actually to explain that to the patient. Dr. Ari is saying, is it better to ask about how this patient likes to read, whether online or in hard copies, whether patient needs a leaflet or online videos? Yeah, that's totally fine, but leaflets are actually a very important thing and a very, what we call like practical thing to offer to the patient rather than just videos. So the leaflets, if you come across any of the leaflets, they might signpost you to go through like a website, specific website, or a specific kind of video. So the leaflet itself, actually a hard copy, or even a soft copy, you can send the patient via text message. I don't know if you know about this. It could be like something what we call like beyond the PLAB-2 levels, but because I work as a GP, I know that you can send leaflets even by texting. It's totally fine, but don't have to waste. So you can offer leaflets. And the way to do that, so I might also provide you with some leaflets at some point. Would that be fine? So you don't have to say what kind, is it soft copy, is it or hard copy? Videos actually, like I said, can be included inside the leaflet itself. Right, good. Any questions so far? Dr. Sherry, can we call the patient's name 2-3 times in the whole consultation as a part of good IPS? You can or you cannot, it's totally fine. I'll tell you what, a lot of doctors actually forget the patient's name under the exam stress. And you might argue they shouldn't forget the patient's name, but there is a trick actually how to overcome this. If you forget the patient's name, you should not actually call them by their name, right? So you use only the pronoun, you use you, and how about, how are you doing at the moment? You don't have to say Mr. Joe, Mr. X, because you might forget, and this happens a lot in the exam where the doctor forgets the patient's name. But if you pronounce the patient's name, or if you tell a patient different name, or address them, or say that they have got like Mr. Mike and we say Mr. John, so that's a massive problem. So if you're gonna forget, please don't mention the patient's name. So you don't have to repeat the name many times. But if you're gonna remember the patient's name, you can do that. Absolutely, that's totally fine, as long as you do remember it correctly. Good. Bear in mind that a lot of people also need reassurance. Why I mention this? That's because some people actually presented to you today, and they are just very, very worried about their condition. This patient actually was like benign prostatic enlargement or something. He's really worried about prostate cancer. And the reason why he came in today here to make sure that he's fine, he doesn't want any treatment for any problems he has got, but he's just worried about cancer. But when you reassure them, they will be very grateful to you. A lot of doctors, and including myself actually, before I started my PLAB journey, I thought that, the management plan is all about treating the patient's symptoms. But believe me, no, it's not. I didn't know that until I came here and I started working. And after a lot of years, now I know what the patient need actually, most of them. So they need, some of them actually, or most of them are after reassurance. But by that, I don't mean false reassurance. If you do think this patient has got a sinister thing, but you're not quite sure about that, so give the best case scenario, worst case scenario. But don't say, oh, you're right, you don't worry, you haven't got any problem at all, you'll be absolutely fine. And the patient ends up by having like a stroke or cancer or something because you just falsely reassured them. That's a very poor communication kind of thing with the patient. The patient will be very grateful when they say, when they hear from you that they are fine, they haven't got a problem. But later on, when they know, they will be very disappointed and they might sue you because it gave them wrong information. You delayed their treatment because you said, no, you're fine, and they have got cancer, right? So the patients, some of them need reassurance, but if you're quite sure that they haven't got a problem, this patient who presented with migraine, for example, and she's worried about brain cancer, but based on the symptoms, based on normal examination, based on her history, you don't think that she's got cancer, she only got migraine. So she will be very grateful if you reassure her, if you're quite sure about that, okay? Breaking bad news in layers, offer emotional support, we mentioned about that. If not sure, be honest and escalate into your seniors. I face that with a lot of candidates actually who always mention about seniors. But I need you to mention about seniors, even in every single station, that's totally fine. But it's about how you're gonna speak about your senior. So please be confident in the exam. Please show the examiners that you know about the management plan and everything, but the senior is someone who is actually supportive and complimentary. It's not about, oh, I'm not sure I'm gonna get back to my senior. This makes a patient lacks confidence in you, all right? So unless it's really, 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 you are really not sure about what this patient has got, you haven't got any clue, and even you haven't got, like I would say, like list of differentials, like a best case scenario, worst case scenario, or you think this patient needs an immediate intervention by your senior, like they are in like in very emergent situations, they need a senior at the moment to come and see them. So this is the scenarios that you are not sure, or you want to include the senior straight away. But if you want to include the senior, you should include the senior, but in a different way. How you do that? And by saying, I'm going to discuss the situation with my senior. At the same time, I do think that you've got 1, 2, 3, 4, 5, or I think that you've got 1, 2, 3, 4, 4, 5, and this sort of like diagnosis and whatever. And also I'm going to speak to my senior about the situation, if that's fine. However, we do think that you need 1, 2, 3, 4 as a sort of treatment. So I'm going to discuss with every single patient you see in the UK, specifically if you're an FY2 doctor, you need to discuss that with your senior, because it's really safe for yourself, it's really safe for the patient. Actually, this patient, actually, you do think they have got, for example, like migraine, but you didn't ask them about a sudden onset of headache. So did this headache actually started suddenly, or did this pain started gradually? And you missed what we call like sentinel headache or subarachnoid hemorrhage or something like that, okay? The senior is really important because they might give you a bit of extra information, or they might ask you, did you ask this patient about this or that? Okay, I'm just speaking to you behind the scenes. It's not in the exam, but behind the scenes. So you're confident, yes, about your diagnosis and everything, but you speak to your seniors as a bit of an extra reassurance to the patient, okay? So the senior is very important in every single station, but just as a discussion. However, if you do need the senior for an immediate action or something, yeah, of course you can do that. If you're not sure, okay, it's fine, but please don't do that in all of the stations. I'm not sure. No. The examiner expects you to be sure. The patient expects you to be sure in the exam. Don't put much stress on you because, like I said, it could be if you're not sure if this patient has got cancer or not. So yeah, it could be something simple as whatever, but at the same time, I don't want to miss anything sinister. So that's why I would like to refer you at the moment into a specialist in a couple of weeks' time, just to have a further look into you and just to make sure that we're not missing anything sinister at the moment. Okay. Right. Never forget follow up if required. That's called continuity of care. It's a very important thing actually to follow the patient up. It's not all about just, all right, so I'll give you this treatment and goodbye. No, please follow the patient up. And following the patient up is slightly subjective thing, slightly. If the patient, for example, if you're seeing a child who is aged like 3-4 years old and presents to you with flu-like symptoms or slightly poorly, and you decided that they go home, that's totally fine. But please follow them up in like 24 to 48 hours. If a patient, like after a procedure and you want to follow them up, you can follow them up in like 4 to 6 weeks time, just to make sure that they are doing great. A patient with headache, you can see them, for example, in like, you start the treatment of migraines, a patient with headache, and you think that they've got migraines, but follow them up in a few weeks time to make sure that their problem is not progressing. Okay, so it's a bit subjective thing, but some people actually need, or most of them actually need follow-up. All right, until you're gonna, unless you're gonna refer this patient into a specialist, for example, and the specialist is gonna take over here. The specialist is gonna arrange all of the follow-up kind of thing, but at the same time, you have handed this patient over into a specialist. So this is a safe thing. So this is called continuity of care. Continue to look after your patient. It's a very important thing. Okay, good. Right. So Dr. Shedi, please few tips regarding IPS in management plan. Right, so we mentioned about this actually. So this is what we are mentioning in here. So the IPS in the management plan starts with explaining the diagnosis, explain that in detail to the patient, offer leaflets. So this is the IPS in the management plan. To explain the diagnosis, explain the investigation results and the examinations that you already done to the patient. So this is an IPS. Ask the patient if they have got, like, if you try to address their concern, they have got a concern, and then they're concerned about cancer. And at the moment, I don't think that you've got cancer based on the type of headaches and based on a normal examination, normal investigation results. I don't think you've got cancer at the moment, right? So this is reassurance. This is an IPS between yourself and between the patient. And then you speak to the patient about the treatment options, symptomatic treatment, for example. Mentions that to them. You mentioned about the senior for the reassurance, and then don't and never forget about, and we're gonna hopefully arrange like a full session about the management plan structure anyway. Speak about the safety netting. It's a very important thing to be safe, because this patient actually, if you don't safety net them and they go home and you don't tell them if they got any loss of weight, loss of appetite, arm weakness, leg weakness, learning of speech, and then they will sue you because they didn't tell them these sort of symptoms, and all of a sudden they have got cancer, terminal cancer, or like TIA or stroke. This is all about your safety netting. So safety netting is part of the interpersonal skills and part of the management plan, because actually building rapport with the patient, referring the patient to the specialist, you did your bit, and continuity of care as a follow-up is also a very good thing in the management, in the interpersonal skills, because you are actually following the patient up. You don't say, oh, okay, thank you very much, see you, go to home, and I don't want to see you again. This is an IPS. The thing is, like I said, you can ask the patient about if they got any concerns, any other questions. You can ask, are we on the same page? Does it make sense? Okay. All of these things actually are considered as interpersonal skills between you and the patient. Right? Good. Right, so I have got like a demonstration. If somebody's actually would like to do this station, we can do it as a mock station if you like, and then we can speak about the feedback if you like. So where you are an FY2 doctor in the A&E department, who the patient is John, 27 years old patient. He presented to you today with chest pain. Speak to the patient, address his concerns, and speak about your management plan. Right? Okay, Dr. Katrina would like to try. Okay, that's fine. Right, so hello, Dr.
Hi.
Katrina. How are you doing?
Hi, I'm fine. Can you hear me all right?
I can hear you. Are you able to hear me properly at the moment?
Yes, I can hear. But I mean, if you want to see me, I can switch on the video. It's just I'm not like in a very good shape at the moment.
It's fine. I mean, whichever you like. You want to switch on the video, you don't want to, it's totally fine.
Like, it's important for the session, I will. It's just I'm not, like, I'm just at home and not.
Yeah,
you can see
absolutely.
me.
I can hear you and I can see you at the same time. That's really good.
All right.
Good. So, may I know, Dr. Katrina, so you're a PLAB-2 candidate, and when is your exam? That's fine to ask.
10th of December.
10th of December. Okay, so you've got a very, very good time before your exam. So all the rest is your exam.
Thank you.
Any questions before we start?
No, I just saw 20-year-old chest pain.
Yes.
To the patient, address these concerns, speak about your management plan. Do I need to examine the patient in such stations?
Do whatever is right. So that's a mock station. Don't worry.
Yeah. Unless the station says like do not examine, I like assume that I examine, right?
You should. I mean, we are all doctors, isn't it? And medicine, I've always got this sort of thing in my mind. Actually, medicine would be too much easier if it's just like a verbal communication and no investigations, no examination, nothing. Would be too much easier actually if you do so. But we are doctors, we should examine patients if necessary, isn't it? So because examination is a part of you knowing more about the patient, and it's a part of your actually data gathering, you gaining information about the patient, isn't it? So it's a very important thing to examine a patient in such stations. And yeah.
Okay.
Any questions? Any other questions?
No. Yeah, I okay. So like you'll be the patient, right?
So what will happen is I will be the patient at the moment, and we'll do this sort of mock station. You are the doctor, of course. If you like, you can take like an hour, sorry, a minute and a half just to read about the stem itself, and then we can start. I've got the GMC timer with me at the moment. I might do like a kind of a demo test for the GMC timer. If you're able to hear it, that's fine. If you're not able, just stop me and say, Doctor, I can't hear the GMC timer. Is that all right?
Yeah.
Good. Once you're ready, just let me know and we're gonna start.
Okay, I'm ready.
Begin.
Hello, examiner. My name is Ekaterina Sorkina. My GMC number is 7986270. May I proceed?
Yes, of course you can.
Hello, my name is Ekaterina. I'm one of the junior doctors here in the department. May I know what is your name?
My name is Joan.
Very nice to meet you, John. Could you confirm your date of birth for me, please?
22nd of June, 1999.
Great. Is it okay if I call you John?
Yes, of course you can, yeah.
All right. John, so what brings you to the hospital today?
Right, so basically my chest pain is actually killing me, doctor. It's really horrible. It started today morning, actually. I don't know what's going on, so I started getting worried about that. So that's why I'm here today.
Oh, I can see that it would be very disturbing. John, okay, could you please point to me where in the chest you have the pain?
So it's about this area.
All right, so more to the left, John, right?
Yeah, to the upper part of my chest, yeah, on the left side.
All right, does it go anywhere?
I don't think it does.
Okay, and how would you describe it? Is it dull? Is it sharp?
I think it's a squeezy type of pain, doctor.
Squeezy type of pain, okay. Has it ever happened to you before?
No, honestly, it's my first time to get such a horrible pain.
All right, and it started this morning, you said, and is it continuous or it comes and goes?
I think it comes and goes. Specifically, when I move or twist, I think it's really horrible.
When you move, you said first,
yeah? Yeah, exactly, yeah.
Any particular movements, like if you try to raise your hand or do something in particular?
Yeah, honestly, when I try to grab something, I feel this pain is actually in here.
All right. When you try, I see. So it gets worse.
Yeah.
John.
Sorry, say that again.
John, does anything make it better? Any position?
I have taken some sort of paracetamol this morning, but they didn't really help, unfortunately.
Okay. And when you lie down or you sit or you stand, it's all the same, makes no difference.
I think specifically when I move or twist, that's the main thing, but when I lie down, I don't think it actually gets worse.
Okay, I see, John. And may I check how many tablets of paracetamol did you take today?
I did take a couple of tablets, yeah.
Okay, all right. And John, if I ask you to grade this pain from 1 having no pain at all and 10 being the most severe pain in your life, how would you grade it?
I would say it's actually like 7 out of 10.
Oh, so I see, John, you're in quite a bit of pain, and we'll address your pain straight away after we'll finish this consultation. Is that okay?
Yeah, of course it is.
So, John, to check what's actually happening, I'll ask you a few yes/no questions. Is that okay?
Mm-hmm. Mm-hmm.
So, John, apart from this pain, you don't have you did not have any change of weight recently.
No, not really, no.
No lumps in
Not that I'm aware of, no.
no fever.
No, I don't think so.
No flu-like symptoms anytime recent.
No.
Okay. And did you have any conditions at all previously, medical conditions?
No, I used to be fit and well.
All right, great. And apart from paracetamol, do you take any medications at all?
No, not really, no.
Mm-hmm. No over-the-counter drugs or vitamins or supplements, nothing like that?
No, just a paracetamol, that's it.
Okay. Thank you for this information, John. I'll also ask you a few questions about your family and lifestyle, if that's okay.
Mm-hmm. Of course you can.
Any disease runs in your family, John?
I think my mother has got high blood pressure, and my father actually died of a heart attack when he was 52.
Oh, I see. I'm really sorry to hear about your father. And you yourself, do you measure your blood pressure ever? Is it okay? Do you know?
Why should I? I mean, I'm normally fit and well, so I'm not complaining of any problem.
Yeah, you're right. Yeah, just double checking. Okay. And about your lifestyle, John, could you tell me about the diet?
Oh yeah, I think normally in the morning actually don't eat much, just like some sort of jam and bread. When it comes to the lunchtime, I normally eat at work, so unfortunately most of the time I eat junky food. I haven't got enough time to cook myself. When it comes to the evening time, I do like jam and bread. I sometimes eat some sort of sweets, to be honest with you, and some yogurt. Yeah.
So I can see on the chart that it's not very well balanced, but okay, we'll see. We'll see if it might have any to your today's problem.
Absolutely.
Do you smoke, John, by any chance?
I've never smoked before.
And what about alcohol?
Just very occasionally.
Mm-hmm. And physical exercise, John?
Sorry, say that again, sorry?
Physical exercise? Any physical exercise?
Yeah, I do physical exercise, yeah. But honestly, it's been a while since I've been doing physical exercise. Apart from today morning, I played a football match with my friends, yeah.
Okay, I see, John. And so actually this pain started during the football match, is that so?
It didn't start straight away during it, but it started like a couple of hours later.
Okay, and may I ask what position did you play in the game?
I was a goalkeeper.
I see. All right. And, okay, so do you have yourself any ideas what might have happened?
I'm just worried, like I said, could it be a heart attack, doctor?
Well, I'll do some basic examinations and I'll be able to tell you more. So far, John, please don't be worried. I can see that it's probably coming from you're worried that your dad had a heart attack, but what you told me doesn't sound much like a heart attack. Sounds more like it's possibly a muscular pain caused by your exercise. But we'll do some examinations and double check that. Is that okay? Does that sound like a plan?
Yeah, that sounds, yeah, thank you.
Okay, so I would like to do general physical examination. In the presence of chaperone, examine your chest, if that's okay.
Yeah,
To
of course.
palpate the chest and chest movements and where exactly the pain is located, if there is any trigger. Or is it 6 minutes?
That's 8 minutes, Dr. Katrina. You didn't hear the 6 minutes bell, did you?
The timer for 2 minutes left. You don't have that.
No, it was actually working. I did really hear that, and then I told you 2 minutes remaining. Possibly you didn't have heard me. That's fine. It's absolutely fine. I know this could be actually the reason behind. You saw that there's a lot of time remaining, so that's why. But yeah, it's fine.
Yeah.
How did you find the station, Dr. Katrina? How did you find it? As a doctor.
Station, I think I made a mistake of not asking straight away. So because you said that the pain started in the morning, and I assumed you sort of got up with this ache, and I shouldn't have. I should have asked specifically, like, what were you doing in the morning before it started, and then it would save me time, I think.
Right.
And so, yeah. Otherwise, it's like probably the worst station in the world.
No, absolutely not. It wasn't at all. It was really nice. Don't worry about that. It's all about them. So you don't have, just a reminder, you don't have to ask the patient what were you doing before this pain started, okay? But you can ask, have you got any sort of injury at all, any recent injuries with any pain at all? You can ask about this. Let's speak about this station in detail. We might need to return back to our scheme, and then we can give you feedback with that scheme, but to be more organized. So introduce yourself properly. You did actually introduce yourself properly. You said your name and your role in the department, which was really fine. You normally say, I'm one of the doctors who are working in the A&E department. If you are an FY2 doctor, I'm one of the junior doctors, or I am one of the doctors who are actually working in the A&E department. That was really good. You confirmed the patient's name and date of birth, which was really good, but you can ask me, how would you like me to call you? Like I said, never say, is it okay if I call you John? I may say, no, doctor, please don't call me John, call me Michael. If I've got a preferred name, I might ask you to call me by my preferred name, right? So I think we've discussed that slightly earlier in this session today. So the patient's name and their preferred name actually is a very important thing. Nice to meet you. Nice to meet you too, doctor. How can I help you today? You did really good. Ask the patient about what's happening, and he told you about that he's actually worried. When he says, doctor, I am worried, please never omit this. Please never let it go. So ask, why are you particularly worried, Mr. John or John? Doctor, I'm really worried about a heart attack. And why do you think so? Because actually, my dad died of a heart attack when he was 52. Oh, I'm really sorry about that. Please accept my apologies. And please accept my condolences. And I'll do my best actually to address that in a few minutes. But I will ask you a couple of questions first to be in a better position to address your concern. Is that all right? Okay, so be empathetic, acknowledge, because that's a verbal cue. The patient told you he is worried. So it's a very good chance to ask the patient why they are worried, where they are coming from. It's a very important thing. And then try to address that at last, okay? Take it early on. Right, nice to meet you. And we said about the open question. From my sort of things, from my opinion, don't say, I might ask you a couple of yes or no questions, okay? This is a bit of, it's fine to say so, but at the same time, I would say in a better position, I can ask you a couple of questions, would that be fine, just to get to the bottom of what's going on? Is that all right? Don't have to say frankly, I might speak to you, I might ask you a couple of yes or no questions, because guess what? When you asked me about the diet, that wasn't yes or no question. So that was an open question. Tell me more about your diet. And the diet itself could be slightly irrelevant in this station in a patient who presents to you with chest pain in the A&E department. Okay? Right. So when it comes to, let's say, Socrates with a pain actually is a very, very important structure you can follow. If the patient doesn't tell you what kind of structure of the pain, you already asked me about the structure, which was really good. And if it's referred or not, which was really good. How would you score the pain for me, which was really good. Anything makes it better, anything makes it worse. That was really good of you. You did really well when you asked me these sort of questions. But you might have forgotten an important question, which is, did this pain started suddenly or gradually? Because if this pain started suddenly, that could be pulmonary embolism, could be a pneumothorax, but if it starts gradually, it could be a muscular pain. If it started gradually, could be GORD or acid reflux, right? So it's very important to ask about, this pain started gradually or suddenly? It's a very important question. Good. So like we said, the concern can be addressed early on. I'm not speaking today about the medical aspect. I'm speaking about the interpersonal skills in this station. Forget about the medical aspect. Speaking about the interpersonal skills. Psychosocial part, this pain actually started just today. So, I mean, I assume that this patient hasn't got much things to do with his psychosocial part at the moment. But like I said, has this pain started before or not? Has this pain happened before or not? Which was really fine. Maftuza kind of thing, the medication, medical conditions, allergies, family history, which was really, really good. But like I said, the diet itself, we don't have to ask about the diet itself in such a station, actually, because this patient presents to you in the A&E department. And it's not only about the diet itself as a relevant question or an irrelevant question, but like I said, the way of us asking about the question itself or the problem itself is how it makes the station go. So what I'm saying is to ask about the diet. How would we do that? To ask about the diet. So do you consider yourself eating healthy? Do you eat much junky food? Do you eat more spicy food than usual? Do you drink more coffee or tea? Right. So this gives you a good information about this, about what might be going on with this patient's diet, if you like to ask. But in this station, could or could not be very relevant. Good. When it comes to the examination part, so that was really fine, but you did mention to me about the chaperone. So it's not a sensitive examination, it's not an intimate examination that we need a chaperone for. So the chaperone is actually someone who will be present for the patient's, I would say, the patient's privacy, just to make sure that you protect the patient's privacy and at the same time you protect yourself as a doctor. For some reason, or at some point, if this patient actually comes and says, oh, this doctor examined my private part without offering a chaperone, and actually you didn't do anything wrong apart from not asking about a chaperone. And what will happen is they will listen to the patient. So if you give me just 1 second, sorry, doctor, I will just one more thing. If you give me just 1 second, I will come back to you just 1 second. My children are in the background. Right, just 1 second. Here we go. Are you able to hear me properly?
Yes, so for the chest examination, no need of chaperone. And if it's a woman?
No need of a chaperone if you're gonna examine the chest you're only examining the chest, you're not examining the breast of this lady, if it's a lady actually, right?
Yeah,
so
yes.
Just the chest examination. And even if that's a man, yeah, you don't have to ask about a chaperone. So the chaperone is only about an intimate examination, breast examination, penile examination, PR examination, or vaginal examination. This is an intimate examination. Apart from that, you don't need a chaperone, right? This patient, like I said, and what I was I about to say, this patient might say, oh, this doctor actually that sexually harassed me when he did the vaginal examination. And nobody is here actually to protect you. Nobody here is to say, no, this doctor was, when I was assisting the doctor and was a chaperone, so this doctor did the examination in a professional way without any harassment. Nobody to protect you at that situation, apart from the chaperone. So the chaperone is to protect the patient and to protect you, but only in intimate examinations, right? Good. Then we can say about the investigations themselves. Investigations, what kind of investigations do you like to do in this station? Dr. Katrina, if you like to participate.
I would like examine the chest and well, apart from like palpation of the muscles and stuff, I would do so I would check vitals, and I would do I would still, I guess, do auscultation, and I would do ECG still, just in case, although it's like much more indicative of muscular pain, but still, since he's in A&E and has family history and is concerned, it's no harm doing ECG. And I guess mostly I would also check just in case that like there is no edema in his legs or any like sign of anything in his legs. And I would check the mobility of like shoulders and joints, and check if there's no like signs of trauma or anything like that. If from that decide whether I want to do the X-ray and if chest X-ray is needed.
Perfect. So when it comes to the examination itself, so the first thing we should do is to tell the patients that we need to examine, we need to check their vital signs, their observation signs, pulse, blood pressure, oxygen, temperature. We'd like to examine them from head to toe. So this is what we call, do you know what kind of examination do we do, or do we say about this, head to toe examination? So head to toe examination is actually the layman language of general physical examination. So please try to avoid general physical examination in the exam as a jargon. So we can say head to toe examination or top to toe examination here in the UK. So what's the general physical examination? The general physical examination is actually the examination where you actually do to make sure that this patient hasn't got any extra manifestations in addition to their main system. So for example, if a patient has got like liver cirrhosis, so you examine the abdomen, but at the same time, you need to examine if they've got spider nevi, if they've got like a sort of congestion in the neck veins, if they've got like any sort of clopping. So this is a general general examination, including if this patient has got any edema in the feet. Okay, so you don't have to mention about every single thing, but you mention about the main system you'd like to examine, which is the chest, and you'd like to examine the patient from head to toe. Then when it comes to the investigations, you're completely perfect in that situation. So you can order some routine blood investigations, including heart enzymes, including chest X-ray, including an ECG as well. Right, so that was really nice. We didn't have much amount of time actually to speak about the management plan, but you
Not at all, yeah, awful.
No, it's not awful at all. Don't worry. It's all about you didn't know about, or you didn't hear just 2 minutes well, which is fine. But I assume that if it was like you hear that, so we might have just run into the management plan. So when you hear the 2 minutes spell, just a general advice for you, Dr. Katrina, and for every candidate, please try to rush to speak about the management plan. So okay, so you are in the middle of like asking some questions in history part or the data gathering part, and you hear the 2 minutes spell. So it's now time to examine the patient, quickly mention about the examinations, and go towards the management plan, not just to keep asking the patient questions. So this is not a time control at all, not controlling your time in the PLAB-2 by that. So when you hear the 2 minutes spell, you should actually give the management plan at least 2 minutes, to 2.5 minutes. This is at least, specifically in the data gathering parts. In the counseling parts, you can give like 3 minutes or possibly more than that, because you will have to ask about specific questions in the counseling stations. But in the data gathering, you should pay attention to details in the data gathering part, right? So yeah, we didn't have much time to speak about the management plan in detail, but you did reassure me that you don't think that this patient, or you don't think that I have got a heart attack based on normal investigation, normal examination, and history actually is suggestive of like muscular type of pain. And just quick kind of thing. So what do you do next? Do you speak to the senior at that time?
No, at first I need to address his pain because he's in quite a bit of pain. Need to give him stronger painkiller, which he already took, because he already took paracetamol. I would give him ibuprofen because it's also usually okay for muscular sort of pain, ibuprofen, and there's no history or indication that he can't take that group of drugs, no bleeding, nothing like that. So I would try that, and then we would see, like, because I'm not exactly sure what's the, if it's just like, because the pain after this exercise, it can be just sort of inflamed muscle, or it can be ruptured muscle tendon, something. It a little bit depends on that, doesn't it? What's the further sort of management? So I would have to see if I have to involve not necessarily senior, but maybe traumatologist if there's like more major rupture than it seems. Otherwise, it can be just painkiller, and then if not, and then maybe like local gels with also non-steroid anti-inflammatory drug like diclofenac locally, if it's just distension, muscle distension, right? Or how do you call it? Myositis, like something like that. Sorry, I'm endocrinologist with my specialty. I'm really bad with
I expected you to be, yeah, absolutely. That's really perfect. That's really perfect. So in the PLAB-2 exam, you act as a FY2 doctor anyway. So yeah, senior is really important. In every single station, senior is really important. You're not sure, you are not unsure about the diagnosis or everything, but you just, for the patient's safety, you should discuss every single patient with your senior. So it's necessary to be a senior in here, specifically even you are in the A&E department, so you can't really discharge a patient without taking the senior's opinion. At the same time, I should think whether I should refer this patient somewhere. Shall I admit this patient, or shall I send him home? In this situation, if it's a muscular pain, I will send him home. Then like I said, I'm gonna speak about the specific treatment, and like you said, of course, that was really great. This patient needs safety netting. Okay, we mentioned about that. If you get any if your pain gets actually worse, if you get any nausea, vomiting, if this pain actually goes to your arm or your shoulder, or if you get any worsening of the symptoms, please at that time seek urgent medical advice immediately, right? By calling 999 or coming back to us immediately. Safety netting is very important. And then you're gonna, do you follow this patient up, by the way?
GP should follow up maybe.
Okay.
No,
yeah.
in a week's time to check that everything's okay. If we mean that it's just muscular pain and there is no really like trauma happened during this game, if it's no trauma. And
when it comes to the muscular pain, sorry.
No, please continue.
Yeah. So when it comes to the muscular pain, so 4 to 6 weeks time, what I'm pointing at is we're not following patients up in the A&E department. So the GP should follow this patient up. Muscular pain can take up to 6 weeks time and possibly longer than this. I've seen patients who've been with muscular pain for a few months time, right? Good. So what kind of thing else do we have to do? So shall we advise this patient any lifestyle advice, for example?
Well, if we have more time, because we can.
Right.
So important follow-up advice for him would be to before playing sportive games, like doing massive physical exercise, to warm up, and maybe every day do a little bit of morning exercise or something like that to keep himself fitter, and then there's less chances of situations like that when he does play friends.
Yeah, absolutely. They should avoid physical exercise actually for at least like few weeks time. This is the main thing. And like you mentioned, you should take some painkillers. There are some extra kind of things that they could apply. Some people say, oh, hot foments. Some people say, no, cold foments. So it's okay. NHS at some point says, oh, we can use like cold compresses. However, hot compresses actually currently can be used to relieve any muscle pain. So yeah, that's all about it. But I mean, you did really great, Dr. Katrina. Thanks very, very much. We wish we had longer time to speak about the management plan, but it's absolutely fine. I totally appreciate that. During no problem, during your practicing with your colleagues or your mentors. So you're gonna pay more attention to this, but that was really very, very nice. I would really like to thank you for participation.
Oh, thank you for thank you.
No problem, my pleasure. Right. Any questions at all? I think there are a lot of couple of questions in here. Let me see. So we need to say, I will have a quick check of your vitals and a head-to-toe examination. Would that be fine? Yeah, I mean, vitals or observation signs, that should be fine. I will do a head-to-toe examination. In addition to that, mention, please, specific examination. What kind of system do you like to examine? Because head-to-toe examination is a complementary examination in addition to the specific examinations that you'd like to do today, which is chest examination, isn't it? I am not speaking about the medical aspect of it today. I might spend longer time speaking about the differentials, including the pulmonary embolism and GOLD or acid reflux and everything. I'm speaking about some interpersonal skills in this station. The most important thing is to be safe, Dr. Ali is saying, that's really great. Giving straightforward diagnosis at the start, like I'm sure this is not a heart attack without ECG is not good. Yeah, that's perfect. Dr. Arjuman, please explain how to signpost for STI drugs and family history of cancer. So family history of cancer, we can say, I might ask you a couple of specific questions that might sound alarming. However, please don't be alarmed. So have you got any family history of any cancers that runs in the family? STI drugs. And no question about what STI drugs means, but I might ask you a couple of specific questions if that's fine. If a patient presents to you with penile discharge, for example, and you want to rule out any sort of syphilis, for example, any chlamydia, gonorrhea. Okay, so I might ask you a couple of specific questions if that's fine, but it's actually relevant to our consultation. So are you sexually active at the moment? Right? Do you practice safe sexual activity? Have you got a stable partner? Is your partner actually complaining of the same symptoms by any means? So this is how to signpost. You don't have to say, I might ask you intrusive questions, because I don't think it's actually like a sort of good skills to say intrusive questions. So why you're asking intrusive questions? I'm not asking intrusive questions. I'm asking relative and relevant questions to what you've got. All right. Any other questions before we end our session today? Right, so it seems that no further questions at the moment. So thanks very, very much, great doctors, for attending my interpersonal skills session today. I hope you really enjoyed it, and hopefully in the future we're going to conduct extra sessions as well. Not only about the interpersonal skills, but we can conduct about different sort of things in PLAB-2. I'd like also to thank MedExam Expert for giving me the chance to actually conduct this session for you today. And please, if you do like my or our actually, I would say sessions, just wait for them in the future. Going to be very, very helpful in your PLAB-2. So Dr. Arjuman asking about the mocks, yeah, of course. So if you can communicate with the MedExam Expert, and I think they have got some sort of communication, so you can speak to them and then we can arrange that together. Don't worry about that. Dr. Etasham Ali, tomorrow, which time your session will start? We haven't got a scheduled session for tomorrow, but we're acting on a session. Hopefully will be next week, but we'll just adjust that and we'll let you know beforehand, so don't worry about that. Dr. Chioma, thanks. Tom, Doctor, it's my pleasure. Thanks very much, Dr. Chioma. I hope you enjoyed it. Everyone, thanks, Doctor. So thanks very, very much for attending our session today. And please, if you got any questions, feel free to ask in the future. You can communicate with med-exam expert if you'd like to attend private mock sessions. And all the best. Thanks very much. Thank you. See you later. Take care.